Bismillahirrahmanirrahim. Alhamdulillahi Rabbil Alamin. Wassalatu wassalamu ala ashrafil anbiya wal mursalin wa ala alihi wa sahbihi ajma'in. Respected Madam Yusrina Abu Bakar, Acting Chief Librarian Darul Hikmah Library IIUM. Respected Madam Nur Hashimah Mustafa, Head of Darul Hikmah Library Kuantan IIUM. Respected speaker for today, Prof. Dr. Cik Suraya Muhammad Zain from Kuliah of Pharmacy. Welcome, Prof. And academic and researchers, library top management, senior management, head units and colleagues from Darul Hikmah Library, IIUM, officials within IIUM and without, ladies and gentlemen, Assalamualaikum warahmatullahi wabarakatuh and very good morning. Let us pray to Allah for barakah and success for this program, and hopefully this program will be beneficial to all of us. How are you, ladies and gentlemen? May all be in afia and Allah protection wherever we are. We wish to extend our warm welcome and thank you for our special guests and all participants to this program on sustainable reimbursement drug policy, in short name SRDP, flagship talk with the topic drug policy, medication use, and community engagement. The talk completed the SRDP flagship exhibition at the IIUM Corner, Darul Hikmah Library, Kuantan. Session will be conducted in both English and Bahasa. This program is brought to you by al-Hikmah Library and live streaming at our official IIUM Library YouTube channel. Before we proceed, we hope to all participants can fill the attendance. The link to attendance is available in the chat box. And ladies and gentlemen, we are very honored today to have our invited speaker from Professor Dr. Cik Suraya Muhammad Zain from Kuliah of Pharmacy, the leader of SRDP Flagship Project. Within 40 to 50 minutes, she will share her team project experience with us. While listening the talk, you are free to post question in the chat box and we will read the question during the Q&A session. All right. Not to waste much time, I am delighted to introduce our speaker today, Prof. Dr. Cik Suraya Muhammad Zain. Let me read some brief information about Prof. Prof. Cik Suraya currently a professor at Kuliah of Pharmacy, International Islamic University, Malaysia, and she obtained a Bachelor of Pharmacy with honours in and a Master in Clinical Pharmacy from the University Science Malaysia, as well as a PhD in Pharmacy from the University of Queensland, Australia. After completing her PhD, she had taken up the post of postdoctoral research associate at the Division Social Research for Medicine and Health University of Nottingham, United Kingdom. Prof. Suraya current research uses large healthcare databases to address how particular medication are being used in the general population and the health outcome associated with their use. She leveraged large insurance claim databases and electronic health records as well as big data analytical method to answer questions about the safety and effectiveness of drug currently used in the healthcare system, as well as how current policy affect the way drugs are used. Okay, I don't want to talk too much. So, ladies and gentlemen, with full respect, I now pass the platform to the Prof. Dr. Cik Suraya Muhammad Zain to share her flagship project with us. Over to you, Prof.
Thank you, Madam Sitino. So, Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Thank you for giving me opportunity to share on the activities that we did for this flagship. It is sharing sessions. So, can I have the slide, please? Okay, thank you. Okay, so I have no conflict of interest and nothing to declare. Okay, in these presentations, I will briefly talk about SRDP flagship and drug policy, and then I will discuss on the research on medication use, as well as the community engagement involving committed and community engagement involving home medication review. Okay, so the focus of SRDP flagship is on the rational use of drugs. So we have three components under this flagship. The first one is research, which is focused on the reimbursement drug policy. And we have two components of community engagement, which involve committed Malaysia, which is people with substance use disorders. And the other community engagement focus on home care pharmacy services. Okay, so the SDG for this flagship is SDG 3 on the good health and well-being, particularly on the 3.5, strengthen preventions and treatment of substance abuse, as well as towards achieving universal health coverage. Okay, so I will talk about the research for the first part. Okay, so the background is that the pharmaceutical expenditure keep increasing every year, As you can see here, it was increased 70% from 2005 to 2019. In 2005 to 2009 to 2009, so it was increased 70%, and then it keeps increasing every year. In 2021, it was given 31.9 billions, and 82% of this one consists of 82% of the total public expenditure. And in 2023, the budget increased again to 36.1 billion for health. So it keeps increasing every year. And then the increase in healthcare costs has been mainly attributed to an increase in the overall cost of medicine, the use of medicines, and public health programs. Okay, we can see a few costs of medicine here. For example, this lapatinib, the cost is about 1,967 per box. It's used for breast or lung cancer. So the price keep increasing, and then it is expected more serious in the near future. The price I got from Susmed. Thank you to Madam Rokia for providing the information on the price. Okay, the second examples of the expensive drug here is this Eylea. The cost is 2,280 per vials, and this one used for disorder of retina in the eye. Okay, and then more examples. Yeah, this rituximab, the cost is 2,000, about 2,000 per vial. And if you can imagine, it require a few cycles, and you have many patients on this. So how much it costs to our healthcare? Okay, same goes to ranibizumab. Yeah, is 1,000 plus for macular edema after retinal vein occlusions. So with this expensive, with this cost of medicine, we are interested to know what is the outcomes of the use of these drugs. Okay, and recently, the newspapers mentions that government now is struggling to maintain free healthcare system in our country. So what we are going to do with that limited budget available? And in this case, IUM is not the exception, in facing the challenge in increasing the pharmaceutical expenditure. And a recent issue regarding the staff requesting for medical coverage to be revised. And at the time of the study conducted, IUM medical coverage is capped at RM 45 ringgit per outpatient clinic visit. So staff requesting for this coverage to be revised. Okay. So a mechanism to tackle this issue, um, to ensure a balance between staff benefit and institutions' financial sustainability need to be devised. Okay, so within limited budget and price keep increasing, we want to know how is the medication used within that limited budget, particularly for the expensive medicines. So this is briefly the aims of the research of this flagship. Yeah. So policy within limited budget, drugs or medical policy or insurance coverage, and how this insurance coverage, with the example of IUM here, of RM 45 ringgit per outpatient visit, influence medication use. And then from medication use, how is the medication used? Is it used appropriately or according to recommendations? Then from the medication use, we want to know what is the outcomes of this use, whether they are getting better,
Yeah.
difference, or getting worse. And then from the evidence that we produce, we will provide to a policy maker, which is provide the funding, or to the clinical practice. Okay, that's briefly the aims of our research. And then we take example the IUM here. So the objective of the research using the IUM database to examine the patterns of medication use in the IUM community, and to assess the medication pricing, total charges per clinic visit, and consultation fees, and to evaluate how the capping systems of 45 ringgit influence the medication use, and to propose a drug price control mechanism for the employer to ensure a sustainable reimbursement drug policy. So this is where the name of SRDP come from.
Oh.
Okay, move on. In terms of the methodology, this is retrospective cross-sectional study. We use the PM Care database, and then we include the data from 2016, 2019, and we include all IUM community, either staff or dependent, who sought the treatment, outpatient treatment at IUM panel medical clinic during the study period. And among the data extracted include a type of medication, cost of medications, cost per clinic visit, consultation fees, and number of clinic visit per staff. Okay, we analyze according to individual patient level. This one will provide the informations on the drug use at the each patient level. It's not at the institutions level. And then we report according to the identified data. We analyze using this data. Outcome measures. Um, we measure the patterns of drug utilizations, measure the patterns of drug pricing and profit margin, and measure the consultation fees, total charges per clinic visit, and we measure also the effect of these above outcomes on the drug use, particularly on the number of the medication dispensed and the number of tablets for each of the medications. Okay, so the study findings, total prescriptions included in the study is 161,000. Total patients involving 10,000 patients altogether, and total clinic visit is about 83,000 for the study. Okay, in terms of common medications prescribed for IM community, we found that paracetamol is the mostly prescribed by our panel clinic, our staff. And the second one is chlorpheniramine, cetirizine, diphenhydramine, loratadine, and diclofenac. So these are the 5 top medication prescribed for IUM staff. Okay, and we are interested to investigate further on the price for paracetamol 10 tablet. How much they charge us for 10 tablet of paracetamol. So the most common is 5 ringgit. This is at the time of the study, 2016, 2019, and now might be different. So 5 ringgit is the most charges for 10 tablet of paracetamol, and the second one is 10 ringgit for 10 tablet of paracetamol. So it's quite expensive here. Yeah. And then others include, some also charge 20 ringgit for 10 tablet of paracetamol. Okay. We then move on the profit margin, how much um, they have a profit margin for the common uh, medicine that they prescribe. Chlorpheniramine, the most common one from Sunword, the drug company. And then for 10 tablet, the cost price is 37 cents and selling at 10 ringgit for 10 tablet. So the profit margin is about 2,000% of profit margin. And then the rest of the drugs also the same thing, the profit margin range. For example, diphenhydramine 66%, diclofenac 930%, loratadine 1,000%. So it's high profit margin. Okay, and then um, we then investigate further on the potential capping the price. This one we use the example of paracetamol 500 milligram 10 tablet, the most common drug prescribed for IM community. So currently, if non-capping, so the cost is about 12,000. So if we cap the paracetamol at 5 ringgit, the cost is about 9,000. Okay, if we reduce the cost, and if we cap at 4 ringgit, the cost is about 7,000. So the organizations can have the cost saving about 25 to 40% with that capping. And then we also investigate in terms of the total charges per clinic visit. These total charges consist of medication as well as the consultation fees. So the most charges for each visit is within 35 to 45 ringgit maximum lah. And some of the charges also more than 45. And then we investigate what actually consists of uh, for, uh, for this 45 ringgit. So usually the number of medication is just one. Yeah, it is prescribed for branded drugs. So it's not surprise if branded drug one medication is already over 45 ringgit. Okay. And then in terms of number of clinic visits and number of drug per patients per clinic visits. So we found that over the study period, the number of clinic visits per patient per month increased by 17%, the number of clinic visits. This actually raised another questions. Why is it the number of clinic visit per patient increase? And then we investigate in terms of number of drugs per patients, number of drug dispensed per clinic visit per patients, and it was decreased by 6.3%. This one means that, for example, before this, patient got three medications, paracetamol, cetirizine, and diclofenac, for example. But now the number of drug dispensed reduced to, for example, two medications, paracetamol and diclofenac only. Okay. All right. And then if we investigate also from there, we investigate the overall drug charges, consultation fees, and total charges. It looks here, the consultation fee increased over time by 100% increase. Okay. And then the drug charges decreased by 39%, and the overall charges increased by 7%. So it is interesting here to look into why is it the drug charges decrease. Uh, according to common sense, yeah, when the time increase, the drug charges also increase. So we investigate why the drug charges increase, and then we found that the number of tablet dispensed, for some of the medication decrease. So this one of the factor contributing to the reduce in drug charges. For example, before this, patient got 10 tablets of paracetamol, but now they might have only 5 tablet or 4 tablet of paracetamol. So they reducing the number of tablet dispensed on top of the number of medication dispensed. Okay, and then it is interesting also to know in terms of the frequency of GP visit per month by IIUM staff. So we found that about 30% of patients visited GP more than 4 times per month. So it means that every week, and then when we evaluate further, mostly this one due to the separate bill for the same patients on different day. This one might be likely due to the charges above 45 ringgit, so that the separate bill need to be given on the separate day to cover for the medications. Okay, so the overall study finding is for health providers, drug price differ greatly across GPs, and mostly with high profit margin. Paracetamol, for example, within 2,000 to about 5,000 of profit margin. And for employees, about 30% of staff visit GP more than 4 times a month, mainly completing drug regimen due to inadequate coverage during each visit. And the 5 common medication prescribed for IM staff include paracetamol, chlorpheniramine, loratadine, cetirizine, and diclofenac sodium. Okay, based on that, and we make a few recommendations. The first one is in terms of price control mechanism, using the multi-layer capping system. So the first layer capping system um, of total amount covered of up to 45 ringgit per clinic visit. And the second layer, capping of price of individual drugs. So here we propose for the most common 5 drug. First, paracetamol, chlorpheniramine, cetirizine, diclofenac sodium, and loratadine. And this drug mainly for acute illnesses, so it will not limit the treatment options for chronic illness. Okay, the implications of the proposed systems. Employer, in terms of cost saving, is about 25 to 40%. Okay, as I mentioned in the previous graph, in terms of the how much it costs and when we cap, how much we can get from that. And then from the patient perspective, they will benefit from the number of medication they can access per clinic visit. So this will reduce the frequency of clinic visits. And then for panel medical clinics, they still can have profit margin for the selected cap drugs between 500 to 2,000%. So it's a win-win situation for all parties here. And then manipulations. The amount of total charges can be manipulated anytime and can occur with any systems. So this one can be manipulated to the maximum allowable coverages, which is 45 ringgit. So it will be no different to the current situation for employer. However, measures need to be implemented to minimize the manipulations. Among the measure that we propose is regular monitoring on the patterns of drug use by the employees, data on patient claims at the individual level need to be obtained from the insurance company for monitoring purposes. And GPs are emphasized to provide detail on individual drug charges and consultation fees upon clinic visit. And employers need to emphasize the above details before renewing the appointment of panel clinics. So these are among the proposed measure to minimize the manipulations. And then this is the summary of the multi-layer capping system. And the detail is like this. Okay, so total coverage per clinic visit at the moment to maintain at 45 ringgit. And then these 5 common generic drugs to be capped, paracetamol, chlorpheniramine, cetirizine, loratadine, and diclofenac, to be capped at 5 ringgit for 10 tablet. And for prescriptions with excess more than 45 ringgit, they can get from the IIUM health clinic or they can get from panel community pharmacy. So for IIUM health clinic, no payment required. If they get from the panel community pharmacy at discounted price. So we have talked to a few community pharmacy who are interested to be the panel community pharmacy for this project. And then drug for chronic diseases, for diabetes, hypertension, all that. So options need to be given to patient, either generic or branded. If they prefer branded, so they use their out-of-pocket money. And then in this case, we encourage generic prescribing. And then in terms of monitoring, need to monitor, this one I have discussed just now, pattern of drug use, individual level of claim, detailed drug charges and consultation fee at each clinic visit. Um, and then in terms of internal measure, to strengthen the IUM health facilities. Okay. All right. So the first one is on the price control mechanism. The second one we propose on the revising medical coverage. So the study revealed that drug costs decreased over the study period, whereas consultation fees and total costs increased. And the number of drug, the amount of tablet prescribed for clinic visits slightly decreased over the study period, which contribute to the decrease in the drug cost. So from the perspective of drug expenditure, decreased drug spending is desired. But whether decreasing drug costs reduce patient access to prescription drugs must be clarified to ensure optimal patient care. Okay? So inadequate insurance coverage, which is increased in out-of-pocket expenditure. Personal communication with GP indicated that most of the charges above 45 ringgit were not recorded. So we are not able to evaluate detail how many percent of the visit that has been charged more than ringgit. So although such situations, I mean out of pocket, would permit patients to be prescribed all necessary drugs when you pay on your own, rising out of pocket expenditure could limit patient access to drugs and affect patient care over the long term. Okay, so increase in out of pocket from the perspective of a social welfare viewpoint, it will lead to higher drug price because a patient pay whatever the price for those who can afford to pay, lower drug use for those who cannot afford to pay. So it will be minimum in terms of drug use and higher consumer drug expenditure, which will reduce social welfare. And the decrease in number of prescribed drugs and tablets may be partly attributable to minimal coverage provided by employer insurance and sizable increase in the patient out-of-pocket expenditure. This one to be investigated further in this. And then this maximum coverage has remained unchanged for many years, and this value is among the lowest of all employer insurance programs. As such, we also propose it is timely revision of this limit, and it is necessary to revise this. Okay, so summary on the research that we did. First, on the multi-layer capping system, prevent inappropriate drug pricing, improve accessibility to better drug treatment, and for employer, they can have financially sustainable reimbursement drug policy, and for health provider, it will lead to rational drug use, and for employer, patient, and health provider, it will be win-win outcome. Okay, so we publish this in a policy paper, and then for future directions, the five drug is just for initial stage. So the capping to be expanded to other drugs. We targeted 50 drugs. And then after we have done all this, so to consider revising the staff medical coverage. Okay, so that's all on the research part. And now we move on from drug policy to drug abuse on the community engagement. So how did we get connected with Committed? Committed is a registered non-profit based organization led and run by former drug user to address issues related to drugs and substance use. This community engagement led by Dr. Ileani, she's the heads of this substance use disorder project. Okay, so when drugs are abused and misused, so it becomes addictions, one of the consequences. And then in US, it become opioid. Uh, now they are suffering from opioid epidemic, and then they need help. Okay, so drug abuse is a form of drug taking behavior that results in some form of physical, mental, and social impairment. It's not for medical purposes. Drug misuse is due to inappropriate use of medications. For example, not following the instructions, that's inappropriate use of medications. Okay, this example of the substance use disorder. For example, sedative and tranquilizer. Example, barbiturate, benzodiazepine, opioids, opium, morphine, heroin, stimulants such as amphetamine, caffeine, cocaine, and hallucinogens such as hashish. Okay, so this morphine, this example of opioids, fentanyl, oxycodone, is used for pain, but then it can be abused also. Okay, so the aims of the collaborations and community engagement with Committed is to guide, educate, and assist these underprivileged populations in overcoming their addiction problem and to improve their understanding on disease, medications, treatment, and leading a progressive post-addiction life, and to develop the capacity building among the staff and clients of Committed Malaysia, and also to symbolize that there will always be a place for them in this world, and then overall to help them change for the better and prevent any negative influences from re-entering and dominating their life through illicit drug use. So to help to help them get back to the community. Okay, so to achieve all that, yeah, we did MOU with Committed. Okay, this was attended by our rector. Okay, and then a few newspaper cutting coverage on this project. Okay, and then we have other activity also, such as we help them on the data management because at the moment their data is like not analyzed well, so we help them how to analyze data and how to manage their data. Okay, okay, and we provide various talk to educate them. For example, on the bengkel and pengurusan and analisa data, on the ubat-ubatan antidepresi and antipsychotic, kerintangan antibiotik. So most of the client actually having many diseases and they are taking multiple medications. Okay, pengurusan kesihatan mental and fizikal pulih, bebas dadah dan akses kepada penjagaan dan rawatan psikiatri dalam kalangan klien Komite Malaysia. This also uh, uh, under ITP ya, under Dr. Hidayah. Hidayah. Okay, alright. So now we move on to another community engagement. So we further explore from how drug policy influence drug use to how drug are used in underserved populations. So we went to Ulu Tembeling villages and Aboriginal. Okay, Kembara Sihat. We did a program on Kembara Sihat, menongkar arus membelah belantara, and this under home medication review, led by Dr. Noni. Okay, so the main aim of this project is to improve their health and well-being. So we did home medication review, health screening, health talks, and other activities. So this project is transdisciplinary project. So to solve people problem from many perspectives, and this project involved all healthcare professionals and many NGOs. For example, MRA, PKD Jerantuk, Majlis Agama Islam and Adat Rustam Pahang, Perkim, and Persatuan Farmasi Malaysia. Okay, so our rector attended that program also. Okay, so we did the home medication review. We went to the patient house and then assess how they use their medications and assess their knowledge also on medication and their disease. Okay, and this is among the Aboriginal community. Okay, a few newspaper cutting on the Kembara Sihat. Okay, so on top of the research, on top of the community engagement, this flagship also is included in the Usrah in Action courses. Okay, so we have three Usrah in Action courses for this flagship. Section 815 for Kembara Sihat, Section 817 for Dare to Dream, approaching the needs of the children at Casa Harapan, and then Section 833, a living lab project approaching the needs of the community at their drop-in center. Okay, profiling for Usrah in Actions at Casa Harapan. This one, Casa Harapan is among the kids which is associated with the parents of using drug or addicted parents. So their kids are sheltered in this place. Okay, and then for Living Lab project, this one is the drop-in center. This among the is a daycare, is a day shelter for the those underprivileged. Okay, and then student participating in the university in action symposiums. Okay, and they got one of the group got gold award for that symposium. Okay, all right. So now we move on to the international collaborations for this flagship. Okay, we have MOU with the University of Colorado for research. Okay, and then we have collaborated with University of Strathclyde for the research on drug policy. Dr. Aman Kurdi and Dr. Professor Brian Gottman. He is the renowned professor in the drug policy. Okay, and then awards. Okay, so this flagship has received the finalist Green Gown Award in 2022. So I would like to thank all committee members here, all the members of flagship for their work hard for this award. And then during the Takrim Day 2022, we received the most impactful flagships. Okay. And then recent one, we received the RCE recognition award for winning the acknowledged flagship project at the RCE recognition award 2022. Okay, RCE. This one for RCE Greater Gombak, my place at committed under Dr. Iliani. Okay, and then Dr. Iliani, head of substance use disorder, also received a community partner award at the university level. Okay, so in terms of appreciations to all members, we have been invited by committed for their Jamuan Raya with Pahang Menteri Besar. And then we have lunch appreciation with SRDP committee members. Okay, to appreciate all their works for this flagship. Okay, so we are towards the ends of the presentations already. We live in a world in which we need to share responsibility. So it is easy to say, it is not my child, not my community, not my world, not my problem. Then there are those who see the needs and respond. So those people are heroes. Okay, so with that, thank you very much. I welcome any questions.
Thank you so much, Prof. Dr. Cik Suraya, for your presentation. It's indeed and very informative and interesting sharing. From the sharing now, we know why the flagship winning award in IIUM Takrim 2022 as the most impactful flagship award project. So once again, thank you so much. And as we felt very delighted to have heard a very beneficial sharing for the speakers, but that is not the end of this program yet, ladies and gentlemen. Now we have come to the question and answer session. You can write your question in the chat box, and I will pass it to the speakers to answer your question. And tuan-tuan dan puan-puan boleh menulis soalan di chat box dan saya akan serahkan kepada yang pakar untuk menjawab soalan anda ini. We have one question, Prof.
Okay, bagaimana maklum balas masyarakat terhadap effort yang dibuat oleh IUM terutama di kawasan kampung? They are welcoming our effort and they really appreciate with what we did, and then they look forward for more program with our groups in future. And then now we are planning for more. We have done follow up for the program, and now we are going to do more in the future. I hope that it answers your questions.
We have more question, Prof. Assalamualaikum, Prof. Untuk community engagement, ada open tak untuk staff dari jabatan lain untuk join your
Yes.
SRDP flagship?
Yes, we are open to all staff. And in terms of community engagement, is on volunteer basis. We don't do the invitations, but it's on volunteer basis. If you want to join, you just come in. Boleh, library, you are welcome to join us. Puan Hashimah. Thank you.
I have a question, Prof. The duration of SRDP, um, uh, you mean berapa tahun the consideration on that? Ataupun selama-lamanya?
The SRDP or the flagship is every 2 years, and this year it will be a new flagships lah, flagship 3.0. So if we want to continue, we need to apply. If we don't want to continue, then we just end here. So it will be flagship 3.0 this year.
Still SRDP?
We will discuss further with the members on that lah.
This is another question. Kalau nak volunteer, what is the process?
Okay, volunteer. When we have the program, we will advertise to all. So those who volunteer, just let us know. Let us the committee know that you are willing to volunteer for that project.
Ramai yang berminat jadi volunteer ni. This from Najatul Akmal. Assalamualaikum warahmatullahi wabarakatuh. Macam mana nak mempersiapkan diri untuk join community engagement?
In terms of persiapan diri, dia tak adalah beria sangat ya persiapan diri. The most important thing is you need to allocate your time. Okay, so everybody is busy, so you must allocate your time. Sometime out of, during weekend or during after office hour. So we need the volunteers to be there with the community.
Ramai yang berminat jadi volunteer ni, Prof.
Okay,
I think
boleh.
it should have person contacts how to join your program and be volunteers.
Okay, all right. So basically, as I mentioned just now lah, if we have a program, then we will advertise. Then you let us know, and then apart from that, you can contact me direct also if you are interested to join as volunteer for our community engagement.
And one more question, Prof. Is 45 ringgit that university provide for staff is for consultation and get the medication from the clinic is reliable or not? What do you think? In current situation?
At the moment, if the price of drug is appropriate, it is reliable. Okay, and then if the price within the recommended margin, all that is not up to 2,000%, so it still can manage for minor illnesses. For example, cough and cold, it require paracetamol, it require cetirizine, it require cough medication, for example. So that three medications still can be covered within that 45 ringgit. Okay, so it is reasonable, provided that the pricing is appropriate.
No question right now in the chat box. So I think thank you for all. Thank you to all participants for your support and cooperation in this Q&A session. Oh, another one question, Prof. The clinic charge extra, especially for antibiotic. Unfortunately, to obtain antibiotic, we need to proportional prescription.
Okay. Yes, for antibiotic, it require the prescriptions, but then in our recommendation just now, the excess of 45 ringgit, you need to the patients can ask the prescriptions from the medical clinic to get from the IUM clinic, with no charges, or with that prescriptions you can get from the panel community pharmacy with the discounted price. Okay, so the main things now is the request the prescriptions from the panel clinic for you if you don't want to pay the extra charges.
We just got the discount from that panels clinic or
Panel clinic, they will include the IM community as the members of their pharmacy, and then some discount will be given to some of the medications if you get from their pharmacy.
okay. So we have actually another question from Madam Nohashima, but about alternative medicine. Is there there's any guidance given to the community?
I'm not sure about these questions. Alternative medicines, whether this one refer to the um, to the drugs given by the panel medical clinics, and then if you got the alternative medicine, is it refer to that case? Is there any guidance given to the community or on the overall use of alternative medicine?
Another
Okay.
question with regard the purchasing from pharmacies, are we allowed to yet or still under proposals?
Okay, so all the recommendations have been given to the relevant party and it has been approved by the UMC. So for the relevant parties to do the further actions. So at the moment it's still under proposal, under their further actions.
Any question from the chat box? Okay, thank you to all participants for your support and cooperation in this Q&A session. Hopefully, all of us will be able to wrap as many input as possible and take for sure from the knowledge and experience shared by our speaker, inshallah. On behalf of Darul Hikmah Library IIUM, we would like to thank you everyone for making time in your busy schedule to join us for the Sustainable Reimbursement Drug Policy SRDP Flagship Talk. Before we end, do not forget to subscribe to the official IIUM Live YouTube channel and click the notification bell so that you will not miss out on any interesting event or content uploaded. Once again, we would like to express our heartfelt gratitude to the respected speakers and participants for your present. We will also like to apologize for any shortcoming and inconvenience till we meet again. I wish you all pleasant day and stay safe wherever you are. Thank you so much, Prof. And wabillahi taufiq wa hidayah. Assalamualaikum warahmatullahi wabarakatuh. And thank you.
Thank you. Assalamualaikum.
Waalaikumsalam.